Hello, and welcome to Quick Look Vasopressors and Inotropes, a secondary part to our first series in relating to shock. So thank you so much for joining me, and I hope this will be straightforward and simple for you to appreciate. Always remember to ask those questions. When we're evaluating patients with shock and when we're making decisions about titration of drips, we need to answer these three questions. Number one, is there evidence of volume? In the breath sounds, in the body weight, CVP, PAD, wedge pressure. Number two, is the volume in the arterial bed? And we're going to evaluate that by the presence of an increase in the systolic pressure as we give volume and by a stroke volume that is acceptable. We'll be measuring that from our arterial line. And number three, are the tissues perfused? So we look at the base deficit, pH, reflecting acidosis. If we have the capability, we'll look at mixed venous gas, SVO2, or central venous gas, SCVO2. And we will also evaluate acute or evolving organ dysfunction. So let's remember our receptor physiology. Alpha-1 adrenergic, most particularly in the arteries, promoting vasoconstriction. Beta-1 adrenergic, most particularly in the heart, increasing the heart rate and increasing contractility. The dopaminergic receptors, which at low doses, typically tolerable doses, 5 to 10 micrograms per kilogram, renal, splanchnic, coronary and cerebral vasodilation, and as a subtype, an overall category of positive inotrope and eventually vasoconstriction. Remember that dopamine is really only used in today's world for patients in heart failure and typically not for any other forms of shock that we see. So as I said, for septic shock, our primary agent, norepinephrine, could be phenylephrine, second line agent, vasopressin, epinephrine. Heart failure, dopamine, dobutamine, and as a second line agent, milrinone, which is a positive inotrope and a vasodilator. Cardiogenic shock, norepinephrine plus dobutamine. Anaphylactic shock, epinephrine or vasopressin. Neurogenic shock, neosynephrine. And hypotension induced with anesthesia, neosynephrine, or following open heart surgery, epinephrine. So we understand the categories of how we're going to apply our medications, but let's start off talking about one of the more common agents, and that would be epinephrine. And the thing about epinephrine is it's very dose dependent. It has alpha-1 properties, vasoconstriction, beta-1 properties, increased heart rate, increased contractility, and also beta-2 properties, most particularly related to the pulmonary vasculature and the airway tree. It is primarily used for positive inotrope and positive chronotrope, heart rate. But remember, it does promote vasoconstriction, so it will increase our systolic blood pressure. And if we are using it for inotrope, you may see a decrease in the diastolic pressure. We frequently will use epinephrine in cardiac arrest and in hypotension following cardiac surgery or associated with septic shock. One of the most important things to remember about epinephrine, more than any other catecholamine, is epinephrine promotes insulin resistance. So what we will often see when we're using epinephrine is epinephrine-induced ketosis, and our patient will be acidotic in relationship to the epinephrine, partially because we promoted insulin resistance and now our patient is ketotic. Very important for us to remember, alpha receptor-induced vasoconstriction is oftentimes balanced by the beta-2 vasodilation. So you don't necessarily have profound vasoconstriction or vasodilation, and particularly at lower levels, beta-1 activity. Norepinephrine, as we know, is a peripheral vasoconstrictor, constricts both artery and vein primarily through alpha-adrenergic activity. Remember, alpha-adrenergic, arteries and veins, vasoconstriction. At higher doses of norepinephrine, you will also induce some inotropic effect with enhanced contractility. And what is really important is that you may actually see some reflex bradycardia as you promote norepinephrine and titrate upwards with your norepinephrine. So always be aware of the effect on the heart rate and the possibility of reflex bradycardia. Now, norepinephrine is a primary drug that is used in any type of acute hypotensive state. So we'll use it with cardiogenic shock, septic shock, after spinal anesthesia, if we've removed a tumor, a catecholamine reflective tumor like a pheochromocytoma, if there's been any sympathomimectomy, if it's because of spinal cord injury or any removal of sympathetic nerve, we will use norepinephrine. For us, it's most common in the ICU in any patient who has significant hypotension. Now, it's important to remember about both norepinephrine and epinephrine. These need to be administered through a central line. There is significant issue associated with norepinephrine or epinephrine being administered through peripheral lines and promoting extravasation of that small vessel and necrosis and sloughing of tissue. For norepinephrine, the antidote for that is Regitine or phentolamine, but the better effect is don't give it through a peripheral line unless it's an absolute emergency and you don't have central line placement at the moment. Vasopressin, which is very beautiful. Remember, vasopressin is not a catecholamine. Vasopressin is a hormone. It's produced in the hypothalamus and it's released from the pituitary gland. It acts on special receptors, and there's actually 4 major categories. We're really only going to talk about one, and that is the V1 receptor. The V1 receptor resides on the vascular smooth muscle in the systemic, splanchnic, renal, and coronary circulations. When we administer vasopressin, our goal is to work synergistically with epinephrine and or norepinephrine in order to promote a better vascular tone response. So our primary goal for our purposes in this talk of using vasopressin are to induce a synergistic vascular tonal response as vasoconstriction. We use it in sepsis to enhance that vascular tone and be synergistic with catecholamines. We use vasopressin in cardiac arrest, which enhances cellular receptivity to epinephrine and shock. And neurologic or renal, we use vasopressin, but that will be the vasopressin 2 receptor that helps to control urination when it's inappropriate. That's the control of diabetes insipidus. For our purposes, vasopressin is a hormone that we use synergistically with norepinephrine and or epinephrine in order to promote the vascular tone, vasoconstriction, and allow us to actually titrate down on our catecholamines. Phenylephrine, not used much in the general ICU, used a lot in the burn ICU and a lot in the OR. It's a pure alpha agonist and it doesn't have any effect on the myocardium. No chronotrope, heart rate, no inotrope, contractility, and phenylephrine causes reflex bradycardia. It actually can promote very profound ischemia because as it tightens the vessel, the tension the ventricle must generate to overcome the resistance goes up extraordinarily. Phenylephrine is also very dangerous when given through a peripheral line. So categorically, what we're going to say now, we'll say it again, you'll never forget epinephrine, norepinephrine, vasopressin, phenylephrine, best administered through a central line. If you ever have to do it peripherally, you must have a written doctor's order. Not a verbal communication, not it's okay. You must have a doctor's order to give it peripherally because of the high incidence of extravasation, necrosis, sloughing. People have lost their hands, they've lost their toes, they've lost their fingers in relationship to this. So be cautious when administering these very significant vasoactive drips. Now we're going to move to the inotrope that I happen to adore, and that's dobutamine. This is a directly acting catecholamine, chemically related to dopamine, except that it has pure beta-1 stimulation, primarily and profoundly inotropic. At lower levels of dobutamine, so that would be at less than 5 in a non-heart failure patient, levels less than 5 in a non-heart failure population, you will see minimal chronotropic effects. In a non-heart failure population at a dose greater than 5 but less than 10, you will often see a significant increase in the heart rate. But not in a heart failure patient because their receptors are very insensitive. So 5 to 10 for them is nothing. 10 to 20 is something that you might see in a heart failure patient, but rarely do we use in the ICU except for a chronic heart failure patient. Rarely do we use doses of greater than 10 of dobutamine. There are no alpha and very little beta-2 effects, and there are no dopaminergic effects, meaning vasodilation of splanchnic, mesenteric, and coronary and cerebral vessels. All right, very important about dobutamine. Our primary goal with dobutamine, do not call this a pressor. If your colleagues call it a pressor, it doesn't matter. You don't call it a pressor. It is not a pressor. It's an inotrope. It's the purest inotrope that we have. It increases contractility and at lower doses will increase the cardiac output because it increases the stroke volume without tachycardia. At lower doses, no arrhythmogenic or vasodilating effects and no vasoconstriction. But as the dose goes up above 5, you may start to see some arrhythmia and you may start to see some tachycardia. And that's your self-limitation. You don't go any higher if you have tachycardia or you have dysrhythmia with dobutamine. Now the onset of action is very rapid, 1 to 2 minutes, and half-life, 2 to 3 minutes. It's a very rapid metabolism. So if I'm titrating dobutamine under a doctor's order, I can't titrate that myself, under a doctor's order, titrating dobutamine, I wait 2 to 5 minutes before the next titration to allow time for action to occur. Very, very useful in low cardiac output states. It's a beautiful drug. Remember, it's an inotrope, not a pressor. It is used for acute and chronic heart failure without hypotension. If your patient has hypotension, they might need norepinephrine plus dobutamine, or if they're pure heart failure patients, they may just get dopamine. But very important to remember, dobutamine is used in patients who do not have hypotension. If you have hypotension, you may marry dobutamine plus norepinephrine. Norepinephrine for vasoconstriction, dobutamine for contractility. Follow the stroke volume. Your stroke volume should go up if you are using dobutamine. We use it a lot after an acute myocardial infarction, although at higher doses it's going to increase the myocardial consumption of oxygen and therefore may extend ischemia. And we use it following cardiac surgery. Again, in the critical care unit, in a non-heart failure patient, you may have an order to start less than 5. For a heart failure patient, you may use 10 to 20, and then for everybody else, limited typically to 10. But by the way, dobutamine is not a titratable drug in the Grady ICU population. We must have a doctor's order. And it is an inotrope, not a vasopressor. I've said it once, twice, 3 times, once more. Inotrope, not vasopressor. Don't call it a pressor. Don't think it's a pressor. Don't titrate it to bring someone's blood pressure up. It is an inotrope. It treats your ventricular efficiency, and we should see stroke volume go up when we place dobutamine on our patient. If we're not looking at stroke volume, it's pretty hard to know if dobutamine is working. Okay. So with any of these agents, particularly with beta-1 stimulants, the number one complication is dysrhythmia. It increases the risk, all these beta-1 agents increase the risk of sinus tachycardia, AFib, AV nodal, rapid or recurrent, pause. Did you see me? Okay. Number one complication, dysrhythmia. Whenever beta-1 receptors are stimulated, we run the risk of sinus tachycardia. In addition to that, atrial fibrillation. AV nodal tachycardia, reentry tachycardia, so a very rapid supraventricular rhythm, or ventricular tachydysrhythmias. So how do we avoid that as best as possible? There's no guarantee, but we're going to limit the maximal dose. As soon as we see tachycardia associated with these drips and we're titrating them up, we're going to notify the provider. We want to have a good discussion about the role of the medication in actually increasing the heart rate. Heart rate, AFib, AV reentry tach, or ventricular tachydysrhythmias. Second complication, it's a big one, man, and that is myocardial ischemia, extension of an infarct, increasing myocardial oxygen consumption. Any beta receptor stimulant can increase your myocardial oxygen consumption. Any alpha stimulant through the process of vasoconstriction increases myocardial work and therefore myocardial oxygen consumption. So again, excessive tachycardia must be avoided. We must discuss that with our provider. As the heart beats faster, there's less time for filling and less time for perfusion. So remember, the ventricles fill on diastole and the coronary arteries are best perfused on diastole. So when diastolic time is shortened, we will actually significantly, profoundly reduce the actual stroke volume because we've limited the time for filling, and we will reduce coronary artery perfusion. This is a really significant problem with the utilization of beta stimulants, and we as the bedside nurse must be aware and evaluate and advocate for our patient. The other issue, of course, is the local effects that can occur if you are giving vasopressors in a peripheral line. So very important to remember, vasopressors and inotropes should always be administered via a central line except in an extreme emergency and always with a written order. Peripheral extravasation of vasopressors into surrounding tissue causes very profound and excessive local vasoconstriction, which means that distal to those vessels you have no blood flow and you will have skin necrosis and you can have profound perfusion loss. So remember, we can use phenylephrine, that's the local treatment in general, 5 to 10 milligrams sub-Q around that area, minimizing local vasoconstriction if it occurs after emergency use in a peripheral line. But above everything else, work to get a central line. Work to get a central line. The other complication, as I've addressed already, is severe hyperglycemia. So catecholamines, particularly epinephrine, but also neosynephrine, and at a much lower level, other catecholamines, actually cause an inhibition of insulin secretion and promote insulin resistance at the cellular level. So the patient may become mildly hyperglycemic, but with a significant ketosis that can occur. This is called epinephrine-induced ketosis or norepinephrine-induced ketosis. Now here's the thing. When we have patients who come straight from the OR after cardiac surgery, they'll be on epinephrine, they'll be hyperglycemic, they'll be acidotic, and they're on an insulin drip. And the number one goal for those patients is to titrate their vasoactive substances down to off. As you're titrating norepinephrine or epinephrine down, what you're going to see is the blood sugar is going to drop as well. So always be prepared as you're titrating down that you may need to also titrate down the insulin, and rather rapidly. In our ICUs, we're so fortunate that we use Glucomander to guide us to insulin increase and insulin reduction. Make sure you're doing your blood sugars on time, and do blood sugars when you're titrating, aggressively titrating epinephrine and norepinephrine down. Be aware if patients are on insulin drips and you are titrating vasopressors down. And then I want to remind you yet again to always ask the questions. Is there evidence of volume? Breath sounds, body weight, CVP, PAD, and wedge. Is that volume actually in the arterial bed? Systolic pressure, stroke volume. How much vasopressor am I having to use? And are my tissues perfused? That's evidenced by base deficit, the pH reflecting metabolic acidosis, SVO2, SCVO2, acute or evolving organ dysfunction. 3 basic questions answers everything about shock. Do you have volume, yes or no? Is it in the right space? And are your tissues perfused? Pretty straightforward. Volume, yes or no? Right space, tissues perfused. So when we differentiate shock, we start with those preload measures. In cardiogenic shock, CVP, wedge, PAD are up. In hypovolemic shock, CVP, wedge, PAD are down. And in septic shock, it depends on what state they're in. In their early stage, they look like they have hypovolemia. And in their later state, they have cardiogenic shock. So depending on where your patient is in their sepsis continuum will determine whether CVP, wedge, and PAD are up or down. Typically early, everything is down. Typically later, everything is up in terms of preload. The afterload measure. In cardiogenic shock, stroke volume is down, cardiac output's down, heart rate is up, blood pressure is down, and the calculated SVR is up. Same as in hypovolemic shock. Stroke volume's down, cardiac output's down, heart rate is up, blood pressure is down, calculated SVR is up. So cardiogenic shock and hypovolemic shock in terms of afterload look the same. Remember, their differentiator is preload. In septic shock, it depends on whether they're in the compensatory or decompensatory state. Remember, early sepsis is relatively hypovolemic, but the stroke volume is up, the cardiac output is up, filling pressures are down, heart rate is up, blood pressure is down, and calculated SVR is down. But their filling pressures are also down. That's why we give volume in early sepsis. Later in sepsis, the decompensatory stage, that's a cardiogenic shock state. Stroke volume's down, cardiac output's down, heart rate is up, blood pressure down, and SVR is up. Okay, so I want to really call your attention to compensatory sepsis with low SVR, decompensatory sepsis with high SVR. And I want to make sure that we appreciate that SVR is a calculation depending on your cardiac output. It's not that all of a sudden your vessels found Jesus and all of a sudden vasoconstricted. It's that early in sepsis, you have a high stroke volume and cardiac output. Late in sepsis, you have a low stroke volume and cardiac output. You do really well to pay attention to that because as your patient's stroke volume starts to decrease, their SVR calculation starts to go up. And the number one thing we can do in this state is to provide cardiac support. Contractility measure, we're only going to be able to assume it. In cardiogenic shock, stroke volume down, cardiac output down, heart rate up, but there is a presence of extravascular fluid, high CVP, high PAD. Hypovolemic shock, stroke volume's down, cardiac output's down, heart rate is up, but there is an absence of extravascular fluid. So the difference between cardiogenic and hypovolemic is the presence or absence of fluid. And again, in sepsis, it depends on whether they're in the compensatory or decompensatory state. In early compensatory sepsis, you have an absence of extravascular fluid. But in later decompensatory sepsis, you have a high presence of extravascular fluid. So I think it's really important for us to recall that all of this information brings us back to those simple questions to let us know where our patient is with shock. And even with the best question, it's not always easy to make the right decision about what therapies are going to work. Oftentimes we try one thing, it worked, and we're happy, but many times we try something, it doesn't work, and we move on to the next step. Sometimes it might seem like chaos because we're moving from one therapy to another, but when we see that one therapy doesn't work, we can't persist with a therapy that isn't actually improving the patient. So the answers to those best questions can certainly help. They don't always make it easy to make the right decision. Your questions, remember, is the volume adequate and in the right place? Is the ejection of blood flow adequate for the patient? And is the stroke volume adequate for oxygen consumption? Now that guides us to the appreciation and understanding of how lucky we are here at Grady Hospital that we can actually monitor LV stroke volume using our flow track. So when you're in the unit being guided by an expert critical care nurse, pay a lot of attention to that arterial-based cardiac output monitor that's known as your flow track, connected to your EV1000, because there I can follow your stroke volume. The salient points are to evaluate all indicators for shock: preload, afterload, contractility. Treat the symptoms that can cause death: profound metabolic acidosis and profound hypotension. And once you've made your patient just marginally safe, discover their problem. Is it hypovolemic, cardiogenic, septic, or of course, obstructive? Treat the problem while managing the symptoms. But in shock, you must treat the problem, not just manage symptoms. So our resuscitation endpoints are generally this: get the CVP to 8 to 12 by giving volume. If your patient's on a ventilator, 12 to 15. Always try to achieve an MAP greater than 65. Get that urine output up to 0.5 mLs per kg per hour. If you are monitoring SVO2 or SCVO2, try to get that to 70%. Stroke volume to greater than 40 mLs per beat, and a cardiac output, stroke volume times heart rate, which supplies tissue oxygenation. These are the macro circulation endpoints, and they're pretty straightforward, and we've talked a lot about them. The micro circulation endpoints: base deficit, normal gap, SCVO2 or SVO2 greater than 70, and a lactate level less than 2 millimoles. Everyone who works at Grady who's had education on sepsis knows about the role of lactate, but don't forget the importance of your base deficit. Tissue hypoperfusion can persist despite normal vital signs. It's up to you to discover whether we have treated our patient adequately and accurately to improve blood flow dynamics and the endpoints of vasopressors, inotropes, and volume in shock. Thank you very much, and I'll see you again soon, I hope. Bye-bye.